Morning, ladies and gentlemen. Thanks, Michael, for the generous introduction. And thanks, Michael, Mighty, Prof, Steve, for inviting me back to talk about the right ventricle and the differentiation between physiological right ventricular remodeling and ARVC. Now, you'll hear over and over today about this problem that we have in sports cardiology, where you have an athlete with ECG anomalies and structural cardiac remodeling, and they're in this grey zone where we're not sure whether they have athlete's heart or whether they have a cardiomyopathy that could put them at risk of sudden death when they exercise. And look at these two echoes as an example. The echo on the left shows a non-athlete, and the one on the right is a professional athlete. And you can see that the athlete demonstrates symmetrical enlargement of all four cardiac chambers, including the right ventricle. Now, how common is right ventricular enlargement in athletes? Well, we looked at this in a study that we published a few years ago, and this is a large cohort of 650 healthy athletes, and about half of them were black. And the white bars show healthy white athletes, the black bars show black athletes. And you can see that, regardless really of your race, about 40%, or 1/3, up to 40% of healthy professional athletes will have marked dilatation of the right ventricle in the range compatible with a major task force criterion for the diagnosis of ARVC. So this is not an uncommon problem. Athletes get big right ventricles. And what about this? This is the other problem. Athletes get T-wave inversion on their ECG. So we know that around 3% of healthy white athletes will have T-wave inversion on their ECG. And anywhere up to 25% of healthy black athletes can have T-wave inversion on their ECG. And this presents us with the diagnostic dilemma. You have an overlap with arrhythmogenic right ventricular cardiomyopathy. And as you can see, this is a condition characterized by T-wave inversion on the ECG, dilatation of the right ventricle, and fibrofatty infiltration of the myocardium. And the reason it's a problem is because we know that around 14% of sudden deaths in young athletes in the UK are due to this condition, arrhythmogenic right ventricular cardiomyopathy. So you can see that it's essential that we make the right call when we see an athlete with a big right ventricle and maybe T-wave inversion. But making this differentiation in this athlete with an abnormal ECG and a big right ventricle is not necessarily a straightforward process. So we looked at this in detail. How do you differentiate the physiological athlete's right heart from ARVC? And we looked at it in this study that we published last year, where we took a cohort of athletes with T-wave inversion. So that's the group which present us with the greatest diagnostic dilemma, your athlete with T-wave inversion. And we compared them to a cohort of athletes that had of non-athletes with ARVC. So athletes versus ARVC. And the tests that we performed were fairly standard tests that are available in most cardiology services around the UK. So we subjected our athletes and our ARVC patients to 12-lead ECG, physical examination, transthoracic echocardiography, cardiac MRI, signal averaged ECG, exercise testing on a treadmill, and ambulatory cardiac monitoring. So these are not very advanced tests. These are fairly standard tests, which in most cases can make that call between physiological and pathological cardiac remodeling. I should mention about demographics briefly, because we found consistently in our studies that the demographics are very important when you're making the call between physiological and pathological remodeling. So you should expect to find large right ventricles in athletes that are male, in athletes that are of large body size, those that compete in endurance sports such as cycling or rowing, and also those that have a large left ventricle, because as we said, in athletes you tend to get symmetrical dilatation of the heart. So for example, if you have a very large right ventricle in a small female athlete who doesn't do an endurance sport, that's a bit more suspicious than a large right ventricle in a large endurance athlete who's male. So I'm going to summarize my findings in these seesaws so that I don't bore you with the detail of the results tables, which you can find in the paper. So the history, of course, is the most important thing when we're assessing our athletes. So you can get a lot of clues just by taking a history. And we found that things like syncope or symptoms at rest or very typical vasovagal syncope is non-specific. So I've put it in the middle here. It doesn't help to differentiate between pathological remodeling and physiological remodeling. Now, of course, a family history of cardiomyopathy, premature sudden cardiac death, unheralded syncope, by which I mean sudden syncope with no prodrome, and exertional symptoms like chest pain or dizziness during exertion should all make you think about an inherited cardiomyopathy. And these are fairly common sense things, really. On the ECG, we had a number of things that were non-specific. So axis deviation, be it left or right, was seen in athletes and patients with ARVC. Partial right bundle branch block, which is often quoted as a feature of ARVC, was seen very commonly in athletes as well. The terminal activation duration of the QRS complex, which is one of the minor task force criteria for ARVC, we see that in athletes as well. And interestingly, regardless of how deep the T-wave inversion was or which territory it was on, be it inferior, lateral, or anterior, didn't help. We saw this in athletes and ARVC. Now, if you had more than one ventricular ectopic on your resting ECG, if you had pathological Q waves or low voltages in the ventricular leads, the chest leads, that was suggestive of ARVC, because remember, the fibrofatty infiltration that you get in ARVC, the fat doesn't generate electricity, so you tend to have low voltages in the QRS complex. Whereas left ventricular hypertrophy and right ventricular hypertrophy were actually more suggestive of physiological remodeling, because we know that athletes get high voltages on their ECG. Early repolarization was more commonly seen in the healthy athletes. And biphasic T-wave inversion, which you'll hear more about from Professor Corrado, whereby the ST segment goes up before it goes down, was suggestive of physiological remodeling. On the echocardiogram, the absolute all-body surface area index size of the right ventricle doesn't help to differentiate these two conditions, because athletes sometimes have larger ventricles than ARVC patients, larger right ventricles. Minor reduction in your right ventricular function on echo was not a discriminator. We saw this in athletes as well. Similar to the process you saw in the previous talk, the athlete can have a sluggish right ventricle at rest, which picks up during exercise. However, we didn't see right ventricular wall motion abnormalities in healthy athletes. Thinning of the RV free wall was suggestive of pathology. Tissue Doppler, once again, very sensitive indicator of subtle, sometimes subclinical right ventricular pathology. And marked reduction in the right ventricular function was very suggestive of ARVC. Now, ratio measures of right ventricular to left ventricular size were very useful, because in athletes, you should tend to get symmetrical enlargement of the right and left ventricle, whereas in ARVC, you may have predominant dilatation of the right ventricle. So if your ratio of right to left ventricular size was low, it was suggestive of physiological remodeling. On the MRI, once again, the absolute or index size of your right ventricle didn't help, because athletes get very big right ventricles. Again, ratio measures were helpful. You ratio your volume on the right to the left. If it's low, it's suggestive of physiological remodeling. And marked reduction in the ejection fraction was suggestive of ARVC. And we never saw RV wall motion abnormalities on CMR, late gadolinium enhancement, or left ventricular pathology in healthy athletes. The signal averaged ECG. Well, the task force criterion says you need one abnormal parameter out of 3 to get a minor criterion for ARVC. We didn't find that helpful in athletes, because athletes do tend to get abnormal signal average ECGs. 1 or even 2 abnormal parameters were commonly seen in athletes. However, if you have 3 abnormal signal average ECG parameters, that was suggestive of ARVC. On the Holter monitor, if you have a high burden of ventricular ectopy, that is suggestive of pathology. We found that over 1,000 ventricular ectopics in 24 hours was a good discriminator of health and disease. And you should never see ventricular tachycardia in a healthy athlete. And finally, what about our exercise testing? Well, pseudo-normalization, by which I mean the T wave going from inverted to upright, or indeed the lack of pseudo-normalization, whereby the T-wave stayed down during exercise, was non-specific. This happened in ARVC, but it also happened in healthy athletes. However, if you get ventricular ectopy during exercise, if you have a poor blood pressure response to exercise or a poor exercise capacity, it's suggestive of a pathological process. And again, healthy athletes should not demonstrate cardiovascular symptoms, ST segment depression, a drop in the blood pressure, or ventricular arrhythmias during exercise. And this is a summary slide that you can find in the paper which shows our poor discriminators, suggestive of ARVC, athlete's heart, and suggestive of ARVC. So in conclusion, ladies and gentlemen, it is vital to correctly recognize cardiovascular disease in athletes. But there is significant overlap between physiological remodeling and disease, and you'll hear this again and again today. Athlete's heart versus cardiomyopathy is a common dilemma in sports cardiology, particularly in black athletes. The issue of athlete's heart versus ARVC is relatively neglected compared to the issue of left heart remodeling versus left heart cardiomyopathies. And the ARVC diagnostic criteria are non-specific in athletes because athletes get big right ventricles, they get T-wave inversion, particularly the black athletes, and athletes get late potentials and ventricular ectopics. However, comprehensive clinical assessment using fairly simple tests that are widely available and demographics of your athlete can help to differentiate borderline cases.